for all the excellent work that you've done. And thank you very much for bringing our attention to this absolutely important issue in our community. So thank you to you and your team as well for bringing this information and this data forward. I have no medical training, no scientific training whatsoever, so some of the questions that I'm going to pose to you may strike you as a bit naive, so I hope you bear with me. I wanted to ask you, what is, in your opinion, what are the primary drivers of tooth decay in the community? So the reason I ask this, just to put this into context, there's other communities obviously around the world that are having this exact same debate as we are here today. And I was looking at articles from Australia, for example. And we know that Australia has a national fluoridation program. They provide fluoridated water to about between 70 and 90% of its population. But you look at articles from the Sydney Morning Herald and other Australian newspapers, and they're dealing with the exact same crisis. They're calling it a tooth decay crisis. There's one headline I'm looking at right now, the Sydney Morning Herald, that states, "Dentists plead with parents to reduce children's sugar intake." What are the primary drivers of tooth decay in communities like ours that don't have fluoridated water, and in communities like Australia that do have fluoridated water?
So you mentioned about the various debate that's been going on in the community. I'll just make a quick comment on that. I just want to present the stats. There are 72% of the communities in Ontario that receive fluoridated water. So there is the majority that receives the fluoridated water. Now, going back to some of the factors that may impact oral health, and I don't want to step on any of the dentists. They are the experts here. Maybe they can have more insight to it. But oral health of any individual is impacted by many, many factors. Behavior is one of the factors, education is one of the other factors, diet is another factor, and also the preventative care and the treatment that they receive are another factor. So our recommendation touches on each of those individual factors. And our recommendation touches on education and prevention piece, our recommendation touches on the availability of these services, and our recommendation touches on the community water fluoridation, which is the most equitable and most effective and cost-effective way of providing some benefit to these individuals. And as I said earlier, there is no one intervention that would take care of it all. We need to work on all those fronts. And there's lots of misinformation out there, and we need to make sure that we are providing our recommendations based on best evidence that is available and to the benefit of the entire community.
But it seems to us from our friends in Australia that putting fluoride in water doesn't stop or limit this crisis from growing, because they're having the exact same conversations we're having here today. Is that correct?
Well, I don't know what's happening in Australia, but what I can say is this debate, there's been a lot of this science that is being used and cherry-picked in terms of where this conversation is going in. This conversation ends in having fluoride or not fluoride, but the issue is oral health, and we need to pay attention to it. We know fluoride is protective, and that is why it is there. And as I said, there are multiple factors that impact the oral health of the individuals. One of those factors are their educational level, their availability and access to preventative dental services, and their behavior in general, their diet. There are so many other factors which goes into the individual level of details, which would be very hard to consider in adding population health level recommendations.
The articles that I was reading from, again, countries like Australia or the UK that do fluoridate water, they're finding that a third of children are not brushing their teeth properly. Only about 1/5 of kids actually see a dentist before the age of 2. I know the recommendation, I think, in Canada is to see a dentist before the age of 1. Is that correct?
That is correct.
A quarter of the kids are put to bed with a bottle, leading to what's called the baby bottle syndrome. The long-term exposure to milk overnight apparently has an impact on caries as well. And also the increase in sweetened drinks like juices, chocolate, and yogurt. So there's a lot of drivers in the community outside of the fluoridation debate that are sort of fueling this crisis. Is that correct? Both in communities that have fluoridated water and in communities that don't. Is that a fair assessment?
Well, when we compare ourselves with other communities, even in Ontario, I don't want to go internationally, but there are communities that have fluoridated water, there are communities that do not have fluoridated water. And even when we are looking at them, our rates of decays are much higher than compared to those communities. So we need to, we can say that there are factors that play into in oral health, which education is one of the factors, and we want to make sure that we are spending and investing time on educating the community to make sure that they are taking good care of their oral hygiene and oral health. But that is not the only thing that was going to change everything.
Now, you mentioned that 70% of Ontarians have access to 70%.
72%.
72% of Ontario residents have access to fluoridated water. What's the proportion in Canada, for example? Because I read somewhere that it was about a third have fluoridated water. Can you confirm or?
The outliers in the community water fluoridation is Quebec and British Columbia, which is pretty good, pretty big in number, and Quebec has the lowest lowest percentage of people who are receiving fluoridated water, and that is.
What is that percentage, doctor?
I believe it's less than 10%.
In Quebec, less than 10%.
In Quebec.
And then you mentioned BC also does
yes.
fluoridated. What's the numbers there?
I don't have that, but it's also less than 10%.
Less than 10%. So, if I can just bring your attention to the oral health report. Again, phenomenal report that indicates that we do have an issue here in the community. Again, I commend you for the work here. In the oral health report, looking at that would be page 429 of 485. This is the screening outcomes for children in schools in Windsor, Essex. This was the screening that was conducted over a 5-year period from 2011 to 2017. I'm not sure if you have that on the screen, but...
No, I don't have that on my slides.
Okay, if you don't. So the question that I have is, you provided a really startling statistic that the number of children that did not require dental care decreased by 43% over the 5-year period. Is that correct?
It increases the dental health needs of the children. It has.
Yeah, I think it says here no care required, and the number of children that did not require care went down by 43%.
No, that is not.
That did not require care. So no care required.
So we're looking at page number 31.
This is 429 of 485. I do apologize. That's the page number that I have on the agenda.
Do you have the figure?
This is table 7.
Table 7.
Table 7. It says the percentage of children where no care was required. In 2011, it was 79.9% of children where no care was required, which means that they're healthy. And that went down to 45.3% in 2016-17. Does that kind of jive? Am I reading that correctly? Or?
So I'll have to invite my colleague who may be well versed with the program that we offer and the children to see that maybe.
Sure.
Okay, so hi, I'm Nicole Dupuy, I'm the Director of Health Promotion. So what you're referring to is the number of children in need of care has gone.
No, I'm looking at this is table,
No care required.
Table 7, and it says no care required. So in 2011, we were doing pretty good. It was 79.9% of children where no dental care was required, so they're healthy.
Right.
And then that number drops precipitously in 2016, 2017, down to 45.3%.
Correct.
Okay, so I'm reading that correctly.
That's correct. So there's less children that have healthy mouths.
Exactly.
Yes.
Right. So the question that I have is so over this 5-year period, you're looking at an average decline of about 8%. But what kind of struck me a little bit is the greatest decline in healthy mouths took place between 2011 and 2013, which is before fluoride was removed from the water system. And this was represented a 15% decline in oral health in both of those years. That's the largest, that's the steepest decline. And this happened before water was removed, or excuse me, fluoride was removed from the system. So I guess I'm just trying to understand, again, going back to my original question, what's driving this crisis that we have here? And it seems like the decline in the health, that precipitous decline, that accelerated decline, was taking place before we removed, or fluoride was removed from the system. And I'm wondering if you could explain that.
So Dr. Ahmed could probably add to it. We also have epidemiologists in the audience who could add to this, but generally when we don't look at year over year. So what we've provided to you is year over year, but from a health perspective or health unit perspective, when we're looking at data, we're looking at a trend. And I do believe that the health unit had said previously how long would it take to see changes, and at least a minimum of 5 years is that standard. Because lots of things go up and down year to year, it's very difficult to explain specifically why one thing goes up or something goes down. So we do look over the whole period, and so we look for change over time. And then we provide an analysis or look at statistical difference, like would that be a change that we would expect, or is it something outside of what would be expected?
And I understand that, but what I'm seeing from these numbers is we were on an accelerator, I guess you could say, in terms of or escalator, I guess you could say, in terms of the escalating crisis in the community before fluoride was removed from the water. So what's happening in our community that, again, even before fluoride was removed, we were seeing this increase or decline, I should say, pardon me, in oral health.
I think you said it right, and my colleagues here would probably agree that and Dr. Ahmed has already said, there's multiple factors that contribute to poor oral health. Many of them have been mentioned. Diet is one of them. Good oral hygiene habits is another. Access to care, treatment, insurance is another factor. Preventative services is another. So it's very difficult to answer sort of your question specifically about what is the specific issue. If you're asking about fluoride, as has been mentioned, it's one preventive measure. It's a very important preventive measure, in particular from an equity perspective. It gives everyone at least the beginning baseline. It doesn't replace good oral hygiene habits. It doesn't replace good diet. It doesn't replace access to a dentist. All of those things need to happen to really see good improvements in our community.
And just to add up to that comment, and we already know that dental health insurance and availability of preventative dental health care impacts the oral health. And if we go back to with the history of Windsor 2007, 2009, when the recession hit the community, a lot of people lost jobs, went out without insurance, and so that could be one of the factors that you may see as a result of not getting to the dentist. Their oral health declined at that time, probably the reason because of the access, and then it continued. And I think what we need to pay attention to is the trend, and that is where the population health expertise comes in, and epidemiology. That if you're looking at the year-to-year data or month-to-month data, we may see lots of variation going up and down, and that is why the trend is important to note and to pay attention to.
So would you agree also that that population, is it possible that population changes have had an impact on sort of the numbers? And the reason I ask is the Canadian Academy of Health Sciences basically states that immigrants experience or newcomers experience more negative oral health outcomes, and I think that's something that was mentioned here this evening. And we know that in the last 5 years, Windsor saw an increase of 10,000 newcomers. These were immigrants, for example, that have been in the country less than 5 years. And we know that 40% are refugees, compared to 15% across Ontario. We know that, for example, Iraq and Syria represented 20% of newcomers, respectively. And we already know that Windsor has a high population of immigrants, 27.8%, which is significantly larger than the population of immigrants across Ontario and Canada. So this influx that we're seeing as well, is it possible that that could be also contributing or driving some of the data that we're seeing as well? I'm just curious.
We definitely looked at the data to take that into consideration with the immigrants that came into our community, and the data showed that there is no immigration effect on these dental health. Many of these analyses are done at the school level, and in our community at every school, these immigrant population are dispersed in every school. What you're looking at is the average of all the children, and that's why I made a point that we looked at the amount that every child in the city of Windsor and Essex County. So it's not just the one school that we took a sample and then we compared it with every other kids. We looked at the amount of every kids that are attending the school. And based on that, even when you factor that immigration part in, how many children are going into school, how many children are assessed, because these assessments are done on JK, SK, and grade 2 only. It's not done on each and every grade student that people are attending. And these immigrants, when they're coming, how many of them are going to JK, SK in grade 2? And then when they're spread out across the city, there is no effect of their immigration on the overall oral health report.
I just want to add on to Dr. Ahmed's point. That's correct. So you're talking about JK, SK in grade 2, so about 15,000 children. So the number of actual children, immigrants or refugee children in that age group is so small, it doesn't have an effect. But they do have an effect. They are residents, and they do matter when it comes to decisions. So to your point that they may have increased oral health needs, I think is a really important point when you're making decisions today. That you do have a lot of residents, including new immigrants and refugees who are now residents and citizens of Windsor, who these recommendations matter quite a lot to.
So when I was doing my research, I was looking for a success story, and I came across a program called the Child Smile program in Scotland. Are you familiar with that program, Child Smile in Scotland?
No, I'm not.
So really quickly, they, about 6 or 7 or 8 years ago, they were having the exact same debate that we were having here today. It's a fluoridate or not fluoridate. And they decided, the national government in Scotland decided they wanted to go beyond the debate of fluoride. And so what they did is they created a program called Child Smile. And what it does is it provides children in daycare and elementary schools in vulnerable neighborhoods, provides toothbrushes and toothpaste, which is what we do in our community. It provides twice annual fluoride varnish applications. I'm not sure if we do that. And it also provides, which I thought was quite innovative, it provides daily supervised brushing in the daycares and in the primary schools. Daily supervised brushing. And a government report found that the Child Smile program increased the percentage of children with no tooth decay from 54% in 2006 to 68% in 2014. So dramatic improvement. So while other countries were seeing a decline, regardless of fluoridation or not, Scotland was seeing a dramatic improvement in oral health in children because of this program. Is this something that we could implement here in Windsor and Essex? Is this a strategy that we could implement?
So let me just comment on the providing the toothbrushes and toothpaste. We do that. There is a program that gives out these toothbrushes and toothpaste to vulnerable children. There is a fluoride varnish program that is implemented in our community, and we do that through, there's a provincially funded program that provides fluoride varnish to children. And when it comes to providing support for, as you said, that helping them brush, it's great. But when we are looking at the population level health intervention, how much it costs. So think about it, is we cannot just say that the responsibility is on them. What are we doing out there for the community? It's about equity. And if we have the funds to do that, that's great. But I think it just goes back to the question of whether it is how much money it costs and how effective those interventions are. And public health interventions are basically recommendations based on the cost effectiveness and the relative effectiveness in the community. And this is what we are recommending. If this can be done, we'll support that. But as I said, there are multifactorial things that we need to consider. These are all the individual level interventions that you can do. And if those individual level attentions have limited impact, and if that can be done, it's cost intensive, and it would definitely show some positive.
It works. It seems to have worked in that country. That's the point that I'm trying to make. One final question, just again a quick question. There's so much literature out there, and honestly, the last 2 weeks I've read so many journal articles, medical journal articles, dental journal articles, you name it. And there's some good articles, there's some not so good articles. There's good methodology and not so good methodology. But there's 2 studies that caught my eye. I just wanted to get your comment on it. So there's 2 studies that were published in 2017 and 2018. Both were published by the University of Toronto. And they were published in partnership with Harvard University, University of Michigan, Indiana University. They were sponsored by, I think it's the National Institute of Health. And what they found in both of those studies is that there was an association between exposure to fluoride in pregnant women and elevated incidences of ADHD and lower IQ among their children. And what was really remarkable about this study is that they actually followed 213 mother-child pairs from pregnancy, and they tested the children, for example, at age 2, at age 4, at age 6, at age 10. So this was a longitudinal study. And the findings, and I'm trying to quote here from one of the lead authors, the conclusion was, our findings are consistent with a growing body of evidence suggesting that the growing fetal nervous system may be negatively affected by higher levels of chloride exposure. They're not saying this is fact. They're not saying that they're not making an absolute conclusion, but what they're saying is we need to investigate this more. There's enough grounds, the methodology seems to be fairly solid. There's enough grounds here that we need to do a little bit more research. Can you comment on that, on those two studies?
Sure. As I mentioned, this document is recently prepared by Public Health Ontario, our scientific body, and it touches on specifically on those studies. And I would just say that the studies, and I'm quoting verbatim, these studies were critiqued by other researchers for methodological limitations, including measurement error and no consideration for other potential explanatory variables such as preterm birth, exposure to tobacco, alcohol, arsenic, or lead, apart from socioeconomic status. The results are advised to be interpreted with great caution due to the high risk of ecological fallacy. Water fluoridation is measured at the state level and confounding biases. And as you know, Councillor, anytime when we are looking at any study, confounding and bias is one of the most important things that we have to look to make any kind of meaningful conclusion. And based on the methodology, if those questions are raised, it raises doubt in terms of what the conclusions, how the conclusions are being drawn, and whether it can be applicable to other communities or other individuals. And refer back to this paper. This concludes that there is nothing to say that it caused any concerns in the neurodevelopment or ADHD, and this is also proven by the European Union for Scientific Community and Health Research. They also said exactly the same thing, that fluoride in drinking water at levels permitted does not impair children's neurodevelopment. So we do have those recommendations right in those documents.
No, absolutely, and you know, association is not causation.
Exactly.
And the researchers themselves, they don't purport to state that it causes or that this is conclusive or whatnot. But I just found it interesting that they seem to imply that they're raising some questions that need to be investigated.
As I mentioned earlier, we do take all the scientific evidence very carefully, and we look at those scientific data and use our best ability to gather all the scientific evidence, all the scientific bodies who are expert in those areas, and make recommendations. We are using all their expertise, collective wisdom of all those agencies, collective wisdom of all those individuals who are conducting those research and present those recommendations in front of you.
Thank you very much. Thank you, Doctor.
Thank you, Councillor. Just a point of fact, Toronto has the highest rate of immigration, not Windsor. Just clarify that. Councillor Gignac.